Thank you, Lily. Can you hear me? You can see the slides?
Brilliant.
Yeah, okay, great. Yeah, my name is Gerben Borst. I work as a consultant at the Christie in Manchester. I also have an academic position at the University of Manchester. I'm indeed going to talk about setting up studies in patients with glioblastoma. But first of all, I would like to apologize, especially to Lily and Matt. I promised to come over to London, but because we just recruited 2 patients in our study, and one of them undergoes planning today, I just did not manage to come over. So my apologies. Second of all, I would like to congratulate Lily and Matt with such a great day with very important topics. Like I said, I'm going to talk about early phase studies. I'm going to be helped very much by the earlier presentations of Ola and Matt. So there will be some repetition in this presentation, but yeah, please let me know if there are any questions during the presentation or at the end. Ola elaborated on the fact that TT-Fields is acting on cells that are dividing, and you see here an example of cells that are dividing. So on the left, you see a cell before its division, and then you see the cell actively dividing into 2 daughter cells. It is important to realize that in that whole cell cycle phase, that early stage is taking much longer. So that can be hours, many hours, or even up to days, where the cell is actively preparing for this division, and the actual division is relatively short. That is only half an hour, maximum an hour. So in 2004, when the first publication about how TT-Fields work, the focus was very much on this cell division and what TT-Fields is actually doing on that. And what you can see here are the different consequences. So we see here that cells are delayed in that mitotic process, in that separation process. We can also see that cells struggled very much to stay alive in that mitotic process. You see here the disintegration of cells that are exposed to TT-Fields and undergoing that separation phase, that mitotic phase. From my research focus, I was very interested in this outcome, especially when the positive studies of TT-Fields in the clinic were presented and published. And the reason why I was intrigued was what I mentioned earlier. Cells only spend a little amount of time in the mitotic phase, and I knew from my radiotherapy background how difficult it is to target cells that are in that short period of time. So I was intrigued, but I was also a little bit maybe skeptic or critical, as in, how is that possible? You see such a clinical impact, but from theory, how is that possible that TT-Fields have such an impact while cells only spend that little amount of time in the mitosis? So what I did is I contacted Novocure and I asked them to work with the system that Ola previously elaborated on. And we extended that system with a microscope. And with that microscope, we were able to look at cells at real time. So you see here the cells in a Petri dish. You see here the application that Ola showed before. You also see the microscope. So in the microscope, we apply the TT-Fields Meanwhile, we looked at the cells. We used a specific type of cells. We used cells that express different fluorophores dependent on the cell cycle phase that they were. So we could track every single cell, and from the color that the cell expressed, we knew in which cell cycle phase they were. And I wanted to know that because I wanted to know what is happening in the cell while it's exposed to TT fields, and how does that relate to the mitosis. So you see here a movie loop of what you actually see under the microscope. And here you see what I just mentioned. At different times, cells express different colors, and dependent on the color that the cell express, we knew exactly in which cell cycle phase the cells were. So with that tracking, we could see whether cells were taking longer or shorter in that cell cycle phase. And what we saw was that control cells, so cells that were not exposed to TT fields, came out of the cell cycle, different cell cycle phases earlier than the cells in the TT fields. And the interesting part here is that that was happening while cells were not going through the mitosis. So the TT fields had an impact on the cell, whereas the cell had not seen any mitotic activity. So that means that the TT fields also has an impact on other cell cycle phases and has an impact on the cells, even if they were not in that separation, in that mitotic cell cycle phase. So for us, that was of high interest because that meant that we could try to target that cell cycle to increase the sensitivity of the TT fields. These are similar curves as Ola showed before. You see here the different treatment arms in the cells that were not exposed to anything, that were exposed to a drug that interfered in the cell cycle, that were exposed to TT fields alone, and to the combination arm. And what we saw was that if we combine the TT fields with the drug, that we increased that sensitivity. We did that with different cell lines, we did that with different drugs, and they all showed the same conclusion. If you combine TT fields with a drug that works outside the mitotic phase, you increase the sensitivity. So this happened quite a number of years ago, and while we were working on it, more and more clinical evidence was coming out. As Matt alluded on, it started with recurrent glioblastoma, then in newly diagnosed glioblastoma. And this was the time period that we worked in the lab on trying to have a better understanding of how TT fields actually worked. In the last couple of years and months, more of these holy grail studies, randomized control studies, came out. And what we know now is that TT fields not only has a benefit in glioblastoma patients, but also patients with brain metastasis, and also in patients with non-small cell lung cancer. So in these studies, patients were also randomized in a group that were treated and were not treated. And in all these studies, there's a clear, and we call it a significant impact of the tumor treating fields. For us, I think a very, very important part is not only that it is effective, but over the last decades, whenever there was a trial effective, it also came with quite a lot of side effects. And I think the interesting part of all these randomized studies is that there are well tolerated, and we see a relatively low percentage of toxicity in relation to the efficacy of the study. And the interesting part between the different randomized controlled trials is that they show a very similar grade and percentage of toxicity, very low or a good tolerability. And now I'm trying to make the bridge to what we are doing here in Manchester, is that all of these studies, TT fields come in at a relatively late time point of a patient's treatment journey. Because in all these studies, the TT fields only start while patients already have seen quite some treatment, either with radiotherapy or with chemotherapy. So what I'm very interested in is, can we bring tumor treating fields earlier on in the treatment, and then specifically of glioblastoma patients, because that is my field of interest and the patients that I treat on a daily basis. So you see here the very difficult pathway of glioblastoma patients. And this pathway is represented by MRI images, where on the top row, you see when a patient is being diagnosed, undergoes surgery, and you see that a large part of the tumor is being resected. And then we see the patients for the radiotherapy. We need to make a new MRI scan to target our radiotherapy. And what we often see is that in that time period, the patients are recovering from the surgery, that the tumor is growing back to a larger or a lesser extent. This is quite frequently that we see that these tumors are active in that period of time. We do know that radiotherapy is helping in controlling the tumor, but unfortunately we also know that despite controlling the tumors grow back. We looked into this phenomenon of tumor recurrence in that earlier phase, so in that phase between the surgery and the radiotherapy. And when patients have this phenomenon quite obviously, we know that their prognosis is worse. And you see that in this forest plot that was explained earlier by Matt. All these squares are on the right side of the one. So all these studies showed that if patients are suffering from this rapid early progression, their prognosis is worse. What we start to learn more and more is the impact of surgery. And I will try to explain that with the use of this cartoon. So this is on the left, the state where patients are being diagnosed, and you see here the tumor cells. We know that neurosurgeons are often not able to resect all the tumor cells. So they leave a portion of the tumor cells behind. But because of the surgery, the environment of the tumor changes, and we call it more hypoxic. So that means that there's less oxygenation, but there are also release of cytokines. And those cytokines that are released because of the surgery have a stimulatory effect on the growth and the migration of tumor cells. So these tumor cells are in an environment that stimulates their growth, their migration, while patients are recovering from the surgery and are being prepared for the radiotherapy. So the point that we would like to make is, why don't we follow the same rationale as has been shown for other types of cancer? And why don't we come in with our treatment earlier on? for example, for esophagus cancer or for breast cancer, we know, or rectal cancer, we know that coming in with an oncological treatment earlier on before the surgery is helping the outcome. So in other words, coming in with an oncological treatment before the surgery is called neoadjuvant treatment, which would mean that you treat the tumor before the surgery, and that what the neurosurgeon is leaving behind has already seen some type of treatment. So in Manchester, we are running one study that delivers radiotherapy before surgery, and we are now in the setup phase of a study that delivers TT fields before surgery. These are very small studies. They only run in Manchester. Is that fair? No, I don't think so. You would like everybody to have access to studies. But it's important to realize that these are first time ever studies. So the first time that we ever deliver radiotherapy before the surgery, the first time ever that we deliver TT fields so early on in the pathway. So they are called safety study, feasibility studies. And it's very important that we are very close to the treatment of these patients. So it's very difficult to have these studies in multiple institutions. But we hope to pick up a positive signal in these studies so that we can justify larger studies in more institutes in the UK in the future. So this is the radiotherapy study, and this is the pathway for patients. So patients are being, they present themselves with a tumor. We ask them whether they want to participate in the study, and if they want to participate, we deliver the radiotherapy before the surgery. So I hope you appreciate that there is a clinical rationale to do so. But it also gives us a so-called window of opportunity, because it allows us to look into the tissue and to see what the treatment is actually doing and try to shine a bit more light in what we can do in the future to improve the outcome of the treatment. And then the patients follow the standard treatment of care with radiotherapy and chemotherapy. So this is what I just explained, the window of opportunity. So the neurosurgeon is resecting as much of the tumor as is possible. So in the patients that have seen treatment, we can then remove part of the tumor that has seen the radiotherapy. Then we can look into this tissue to have a better understanding of why is a tumor responding or why is a tumor not responding, and what can we do differently in the future. So what we want to do, similarly to the radiotherapy study, is to do this with the Optune treatment. So once patients are presenting themselves with a tumor, we ask patients whether they want to participate in the study. And if they want to, they will start the treatment before the surgery. So in the preparation phase for the surgery, patients are already on the treatment. And after the surgery, the patients are being asked again to restart the tumor treating fields in the waiting time for the radiotherapy. So this will be the very first time that tumor treating fields is then applied at such an early stage. And we mostly will focus on whether this is possible, whether this is safe to do so. And in the meantime, we of course hope that we pick up a signal that shows us a form of efficacy. And for that, we do MRI scans so that we can look on the MRI scan whether there's any signal that shows a difference with patients that do not undergo this treatment before surgery. it's very difficult to set up these studies because of different reasons. You need to find the money, but you also need to make sure that you do it very robustly and in the most safe setting. So the two studies that I've showed you with the radiotherapy and the TT fields, they have taken us about 2 and 3 years respectively. So that is a very, very long time, and I think that is very unfortunate. And I think it will be very important in the community that we start talking with each other, and then especially with the places where these studies run, how we can speed up this implementation of these studies. So now, after we have been working on this for almost 3 years of this study, we are about to open. Like I said, the funding is there, the ethical approval is there, and we are now in the phase that we are actually setting up the device. One complexity is that TT fields is still relatively unknown treatment modality in the UK. So the trust is not familiar with the device, and all the departments would like, of course, to understand what the device is, how it works, and that is also understandably, but it's delaying the setup of a study significantly. So I hope, and we are going to talk about that later this afternoon, that Optune is becoming available for the broader patient population in the UK. So this is my last slide, and Matt already alluded on this as well. It is the most recent treatment modality in oncology, and it will be very important for us to stay critical and ask ourselves the right questions rather than doing what is practical, because we need to know what are the best co-treatment strategies and what is the best timeline of which modality. What do you need to do first? Which things are you able to do together? And I think with a modality that is effective in different types of cancer, it will be very important for us to know if we move that modality more upfront in the pathway, is the modality bringing more efficacy, especially with such a mild toxicity profile. So this is the most important slide. Of course, I need to thank a lot of people, and especially the people behind the scenes of studies like this, and that is especially the clinical and the research team here in Manchester. They are the driving force of getting these studies up and running. But I really would like to acknowledge the patient representatives, because they have been very, very instrumental in setting up these early phase studies. So Grant Stobart for the Portrait study and Peter Buckle for the POBIC study, for the radiotherapy study. And also organizations like the Brains Trust are very, very important, because we can come up with these ideas, but they will only be translated into a clinical study where patients want to participate if they explain to us and help us in setting them up, having the right communication, having the right setting for a patient, that they feel comfortable and reassured that to participate in the study. So a big thanks to them. That was the end of my presentation. I'm happy to take any questions.
Thank you so much for such a wonderful presentation, Dr. Borst. So I can see Faye has her hand up, so I'll pass over to Faye first.
Thank you. Thanks very much for that talk. That was great. My question is a little bit selfish, because I'm also setting up a neoadjuvant trial in glioblastoma. First of all, I completely agree with you that it's really important to deliver these trials up front, particularly when we're going to get tissue, so that we can interrogate that tissue and understand why or why not these therapies are working. My question is, how much of a struggle did you have in terms of regulatory approval and also patient acceptance of delaying standard of care surgery in these studies?
Yeah, it's definitely not a selfish question, because I know how difficult it is and how uncomfortable you feel in setting up these studies. With the preoperative radiotherapy study, it was less of a struggle from a regulatory perspective, but it was quite a struggle for the whole treatment pathway. So how we need to make sure that we get the radiotherapy in before the surgery, so that puts a lot of pressure on the radiotherapy department to get the scans, to get the planning, and to start the actual treatment. So from that logistical perspective, that was quite challenging. For the portrait study for the TT fields, it was the regulatory approval was not that difficult, because it's a CE marked device. It's MHRA approved. But the collaboration between a trust and a commercial party in a medical device is quite a struggle, and drugs study people are more familiar with, and is I think relatively easier than this. But I hope with our experience and a little bit exploring this pathway, that for other studies it will be a little bit easier, and I'm really excited that you and other people are really exploring and trying this venue as well, because I think we owe it to the patients to finally start with this neoadjuvant approach in brain tumor patients.
Thank you for such a detailed answer. So I'm going to only leave one more question, and that's for Alex. And I'm sorry for those in the room, but we will come to question and answer in the interest of time at the end of the day. So Alex, would you like to
Thank you. Mine wasn't a question, it was just a massive thank you, because I'm being treated at the Christie, and Salford, Mr. Coop was my surgeon, so I just wanted to give you, it's great to see both hospitals working together. The Christie's amazing, and so it's not a question, it's just and the trials coming forward will make a difference to those future patients. So thank you, Dr. Borst, and all the team at the Christie's.
Okay.
Phenomenal. So thank you.
Thank you. So in that case, do you have a question in the audience here, or can I move over to Dr. Mohammed and lung cancer? I will move over, and I know we're running 20 minutes behind schedule, so you just, in the interest of time, we will keep the timings as we are going along, but we will then reduce the lunchtime so that we will restart the afternoon sessions at 2 o'clock, but we're not going to reduce any of our current sessions. So I'm going to stop recording. Sorry.